So we have come a long way in how we care for people with autism. This is a picture of Norristown State Psychiatric Hospital in 1903. In the 1950s, there were 100 million people in the United States, and 550,000 of them had spent at least one night in a psychiatric hospital that year. That was the high point or low point, depending on how you count, of our institutionalization of people with psychiatric and developmental disabilities. And we used to be very proud of them. In fact, this is from a postcard. We had postcards of all of our state psychiatric hospitals. The problem, of course, is that they don't look that way now. We know that's not the best way to care for people with psychiatric and developmental disabilities, including people with autism. In 2009, the state of Pennsylvania asked us to go into that particular hospital, Norristown, to look for adults with autism. They were sure that there were adults with autism who had been misdiagnosed, probably with schizophrenia, and they wanted us to try and find them and see if we could improve treatment for those folks. I was very skeptical of this, but was happy to oblige our community partners. And so we went in and found that of the hundreds of patients who we assessed, 10% of them had undiagnosed autism, or at least undiagnosed at that time. One of the challenges we had was that many of the people were on many medications. As many as 8 or 9 psychotropic medications concurrently, and so it was very difficult to do a clinical assessment. So we ended up going into their records a lot, and they had piles of records. Some of them had been there for decades, including this guy, Ben. So Ben had been admitted to Norristown as a boy in 1955, and we found his initial notes. His mother, he lived in the Philadelphia area, and his mother was very concerned about him because he was having a lot of difficulty in school. They put him in they put him in a special school where the teacher in the early 1950s developed a behavior chart for him, which worked really well. But he had a lot of strange behaviors. He would flap his fingers in front of his face like this. He was echolalic, so if you asked him, "Do you want a drink of water?" he would respond, "Do you want a drink of water?" And he had a younger sister, and the mother, around the time that sister was born, the mother took him to see Leo Connor at Hopkins because she didn't know who else to go to. And Connor described him as psychotic, which is, we used to think of autism as a psychotic disorder, and suggested that he would be increasingly difficult to handle, that his behavior would probably make his younger sister uneasy and be a source of social embarrassment for her. And for this reason, primarily, he thought that the boy should be put in one of Pennsylvania's many fine psychiatric hospitals. Well, the mother refused to put him in the hospital, brought him home, kept him in the same school, but he became increasingly violent towards his younger sister, and she didn't know what to do. And so she ended up hospitalizing him. And the reason we know this is because one of the ways we tried to diagnose autism in these folks was to call relatives, to track down their parents if they were alive, or a sibling if the parents were not available. And she, at the age of 92, completed the autism diagnostic interview with us, and she still agonized about this decision that she had. She still agonized about this decision she had to make for her kid. So he suggested that there were two possibilities: put him in the hospital, put him in a dog patch family was the other one, which is a rural family that wouldn't be concerned with social niceties. So we diagnosed him with autism. We talked to his treatment team, and they took him off his meds, and he spoke for the first time. He spoke to one of the staff members. He said, "I'm very angry with you, Richard." I thought that was like probably decades in the making, right? Anyway, problem is that this is what these psychiatric hospitals look like now. Despite our best of intentions about these more secluded these more secluded settings, they often deteriorate, they often devolve, and we end up providing not the best kinds of care. And I think for two reasons. One is the idea of witnessability, right? So the idea that no one can see what that clinical encounter looks like. And without the ability to see what's happening, there's often leads to the second problem, which is a lack of accountability. That is, we don't have good systems in place to actually observe what the treatment is, what the care is that's being delivered. And in part, in response to that, we have made really significant changes as a society, and we've passed tons of policies that change the way that we care for people with autism and people with other psychiatric and developmental conditions, starting with the Community Mental Health Act, which was passed in 1959, and Medicaid, which was passed in 1965. We changed the education system in 1976 when we required that all children have available to them a free and appropriate public education. We started developing Medicaid waivers, which allowed us to use public health care insurance to cover groups that traditionally wouldn't be eligible for Medicaid. And in 2005, Maryland passed the first Medicaid waiver that allowed that state to use Medicaid dollars to support children with autism, even if their families didn't meet the income criteria. And most recently, we've passed autism insurance mandates that require states to cover care for individuals, require insurance companies, to cover care for children with autism. Before, autism, as I'm sure many of you know, if you're parents or providers, was often excluded, or coverage wasn't to the level that we needed for those folks. So it's very exciting over the past 5 decades, almost 6 decades, the changes that we've made as a society to help move people out of institutions and to receive the support that they need in their communities. So about 10 years ago, we did a survey of Pennsylvania families. And we did a survey of about 1,000 families, and one of the questions we asked them was, has your child ever been psychiatrically hospitalized? And we divided the sample in half. So the green line are children who were born between 1983 and 1994, and the blue line are people who were born, children born between 1994 and 1999. And we asked them how old they were when they were hospitalized. And so we can look, if you look at the y-axis, that's what's your probability of ever ending up in a psychiatric hospital. And along the x-axis is how old you were. And what you can see for the green line is that by the time kids got to about age 10, about 5% of them had been in a psychiatric hospital. If you look at the blue line, so these are younger kids born more recently, and if we were getting better as a society at keeping people out of hospitals, we would expect that blue line to be below the green line, right? That fewer kids were hospitalized. But in fact, more were hospitalized. 12% of younger kids were hospitalized. So why is it that we are passing all these policies, constructing all these policies to support keeping kids in their communities? We are increasing the availability of services to keep people in their communities, and yet the risk of hospitalization is going up for successive birth cohorts. Well, I want to talk about 2 aspects of that. I'm going to pick on 2 policies and talk about what they've accomplished, and then talk about what they haven't accomplished. And 90 minutes is a long time to talk. I can't talk for, well, I can talk for 90 minutes this year, but I'm not going to talk for 90 minutes. And I'm hoping that we can have a conversation about some of the policy ideas we have that where policies have missed the mark, and how we can change those policies to improve the care that people receive and increase the probability that they'll stay in their communities. And I'm talking about the autism insurance mandates, where we've done a lot of research, and also some of the Medicaid waivers. All right, so there were, this is the last state to pass one, Alabama. I'm sure it's not the only thing they were last in, but since 2001, Indiana was the first state to pass a mandate. And by now there are 46 states that have passed autism insurance mandates. And most of these mandates apply only to people who receive insurance through their employers, and only if you have an employer that has more than 50 employees. Right? And what they say is if you are in what are called those commercial insurance plans, they require, they vary from state to state, but mostly they require that you cover diagnostic services and assessment services for kids with autism, and that you cover treatments, mostly behavioral treatments, but also a lot of other treatments as well, depending on the mandate. That applies to about 50% of people who live in most states. So 50% of people in most states have those kinds of commercial insurance products, and 50% are self-insured, or they work for a company that insures itself, so doesn't have to have a mandate, or they work for a small employer. And small employers, that is employers who have fewer than 50 employees, are often exempt from these kinds of regulations. And that sets up the potential for a really nice natural experiment. Right? So we can look at what happens to kids with autism before and after these mandates are passed, and we could compare kids within states who had that insurance versus didn't have that insurance, and across states. We can look at states that passed mandates versus states that didn't pass mandates. And this is what we find. The first thing that we find is that some more kids with autism get diagnosed, not as many as we thought. And insurance companies were very opposed to these mandates. And one of the reasons they were opposed to them was they thought, well, kids with autism will just come out of the woodwork, right? Everyone will get diagnosed with autism, and it will cost us a lot of money to treat them, and everybody's premiums will go way up. Well, that didn't exactly happen. So if you look at the blue bar, in the first year post the mandates, there's no difference. It takes a while for the mandates to ramp up and for providers to come into network now that there's this new benefit. But by the second year, there's about a 17% increase in the proportion of children diagnosed with autism, and by the third year, it's about 18%. So gradually, more kids get diagnosed. But look at the y-axis. The y-axis is prevalence per 1,000. So if we think about 1 in 100 kids has autism, we're off by like an order of magnitude, right? We're still certainly not every child with autism is getting treated through their commercial insurance. Now, what is happening is that among those kids who are getting treatment, they get much more treatment than they used to. At least if we monetize that treatment, like I take all the services that they get, and I can look at the ones that I think of as autism specific. So behavior therapy, speech therapy, occupational therapy, those kinds of things. I can add them together, and I can compare the kids who were in a mandate versus the kids who were not in a mandate. And 1 year post the passage of the mandate, those kids were having about $58 per month more in services spent on them. By 2 years post, it's $113 per month, and by 3 years post, it's $150 per month. So that's a difference of like $6,350 for kids in the mandate versus $4,500 for kids not in the mandate. That's actually, when people who study policies like this, they think that effect is huge. So by comparison, if we look at the Mental Health Parity Act, which also included people with autism and required that mental health care be provided at a similar degree as physical health care, that resulted in a $150 annual difference. So just a little over $10 a month. So the mandates have been an effective tool in getting more services to kids. We're going to come back to the question of whether those are better services, right? Now, spending in commercial insurance is dwarfed by spending in Medicaid. I don't think you guys leverage Medicaid in California the way that many other states do. And it's something, when you think about mechanisms for funding care for people with autism, I think that this is like looking at Medi-Cal and its potential to be leveraged to provide support to people with autism regardless of income would be a really important mechanism for you guys to consider. But this is some work that Lee Wang and some colleagues of mine at Penn State did, that outpatient services on annual outpatient services in 2013, when they did this study, were $20,000 in the Medicaid system versus $3,000 in private insurance. So that's per person. So if you were enrolled in Medicaid, you were receiving a lot more outpatient services, at least from a dollar perspective, than you were in private insurance. Slightly more money for medication, and the only place where commercial insurance was paying more was inpatient hospitalization, maybe because they weren't providing more outpatient services, right? Now, the waivers have been, Medicaid waivers are a mechanism that states use to provide, to use Medicaid to provide care to people who otherwise wouldn't be eligible for Medicaid. How many people here are familiar with Medicaid waivers? Good. So most of you know that a waiver has to identify a specific group of people, and those people can be eligible for Medicaid either by virtue of their condition, or they can be eligible for a type of Medicaid reimbursed service that isn't part of a state's Medicaid plan. And there are 11 states that have passed Medicaid waivers that are specific to autism, that are attempting to increase the amount of services that are autism-specific services that are delivered. And now if we think of the waiver, the goal of the waiver is to keep people out of institutions, right? And so we can try and compare people in waivers to people not in waivers to see if it does keep people out of institutions. People on waivers tend to be more impaired, so it's hard to figure out the right comparison group. So one way that we tried to compare people on waivers was to compare them to people who are in the disability category of Medicaid, and we also compared them to anyone who had an inpatient stay or is in long-term care, and that's what IPLT stands for. So people on waivers were less than half as likely to end up in a psychiatric hospital or in long-term care as people on disability, 2% versus 5%. They received a lot more outpatient care, so that's good, because that's what the waiver is supposed to do. When they were hospitalized, the expenditures they had for that care were less than people on disability. They had a lot more outpatient expenditures, right? So they were receiving 3 times as many outpatient expenditures as dollars versus worth of services as people on disability, and their total expenditures were high. So waivers may be effective at keeping people out of hospitals, but they weren't efficient in terms of the total bottom line cost for these folks. Now, one question you may be asking, certainly one question we asked, is, before I get to that question, which I'll still be asking, one of the things Doug Leslie, again at Penn State, is very clever at matching these Medicaid data with survey data, right? And so he can look at, he has all these national surveys that the CDC fields, and one of them asks the question of families of children with autism, does your child have any unmet healthcare needs? And it turns out that that Medicaid is great, and those waivers are great at reducing parents' perception of unmet need, regardless of income category. So if you have less than 150% of the poverty level, there's sort of a 25% reduction in your unmet need. That's an unfortunate double negative. It's just the way the question is asked. But if you were really poor, greater than 400% poverty, it was really effective at reducing unmet need. And it suggests that waivers are really beneficial to our most challenged and most vulnerable children and families. So we were very interested in what services were causing this effect, right? Was it really good speech therapy or physical therapy? Were there ABA-specific services that families were getting that might reduce their risk for hospitalization? And so we took a lot of years of Medicaid data and we looked at what services kids got, and we looked at how those services in one period of time reduced their risk for hospitalization in the next period of time. And all right, any guesses as to what the most important service was? You gotta shout it out. What? Behavior therapy? That was my guess. Anybody else's? Speech. Oh, I'm sorry? You win. In-home support services and respite care. Respite care was the biggest predictor. The more respite care you got, the less likely your child was to end up in the hospital, right? Those services that we think of as therapeutic had zero effect on whether you ended up in the hospital. Now, there's all sorts of bad things about this study, right? And one of them is we have no marker of severity. The only marker of severity we have was how much service you got, right? Which is exactly the association we're trying to look at. And more severely impaired kids may be more likely to end up in the hospital and receive more services. But they're probably also more likely to receive respite care. So it was really interesting to note a very strong effect of respite care in reducing hospitalizations, but no effect of speech therapy, occupational therapy, behavior therapies. And so we started to wonder, why are these therapeutic services not therapeutic? Like, what's happening that these therapeutic services are not resulting in a reduction in hospitalizations, if we think of that as an outcome that's important and that should be a benefit of receiving those services? Well, we know, and Connie and Tris talked about this at length this morning, we know how to make powerful differences in the social ability and cognition and adaptive abilities of people with autism. So here's a list of studies, the number of studies on autism treatment from 1995 to 2014. I think that this dip is when Connie and Tris went on vacation. But if you take that out, there's been a steady rise in the number of studies about autism intervention. And we can look at what we call their effect size. So the effect size, one way to think about the effect size is how much of a difference on average does this intervention make on the dimension of interest for these kids with autism. And when we get to effect sizes of like 1, we're really happy about that. We think about that as a large effect size, right? Maybe you won't write a letter home about it, but you definitely send a postcard, right? It seems like we really know how to do this in these university-based studies, right? So then a question is, well, what happens in the community, which is where my heart lies and what I'm most interested in. This is what happens, this is what is possible, right? This is what could happen. And so the question then becomes, well, what is probable? What does community service look like, and what are the outcomes associated with that? So one of my very enterprising doctoral students, Alison Namias, took all of the control groups from these studies, and she looked at that same effect size in the control groups. And now this is just over time, what difference, what was the improvement in children with autism on a variety of dimensions. So each of those lines represents one of the studies. The line is sort of the 95% range of outcomes, and the bar is in the middle is the mean effect size. And when you average all those together from all those studies, for cognition, we see an average effect size of 0.26. So that's tiny. And it's actually even tinier when we compare it to those other effect sizes on the first slide, because on the first slide, those effect sizes have this effect size subtracted out of it, right? So these are really small effect sizes, even smaller for improving adaptive behavior. So smaller for social ability, and small for communication. So in all 4 of these domains, when you look at what's happening in the community, the effect sizes we're observing, using the same measures that we use to measure outcomes in the university trials, are much, much smaller. We have what David Chambers from the National Institute of Health refers to as a voltage drop, right? We see high voltage outcomes in university and very low voltage outcomes in most of our community programs, and certainly our community programs on average, right? And this, so why, right? Why, even though we know what to do, is it that we're not doing it in the community? Or is it that we're not doing it well? Or is it that the kids are different? What's happening that's different? And this is the way that I began to think about it, right? So I think about efficacy, right? Efficacy is the what's possible, right? Under ideal circumstances, like those university-based trials, what kind of outcomes can we achieve? And so how does that work? Well, the way it works is that I'm actually not an intervention developer, but we're just going to pretend for a second that I am an intervention developer, and I develop an intervention, and I submit a grant proposal to NIH, and they don't recognize my genius right away, so I submit it again, and finally I get funded, and that grant gives me the funds that I need and the resources that I need to implement the intervention exactly the way that it's designed. And the clinicians that I use to implement that intervention are all my graduate students or staff that I hire, and they're all highly motivated and highly trained, and they're all a little afraid of me, and their dissertations are dependent on good data. My staff are not afraid of me. I wish they were a little more afraid of me sometimes. Right, so the intervention, and the supervisor watches. I watch them deliver it, and if they don't deliver it exactly the way it's designed, I coach them to do it better. And if they can't do it, well, then this isn't the job for them, and they end up somewhere else. And it also turns out that when I conduct these studies, it's perfectly reasonable for, reasonable is the wrong word. You put that in like big fat air quotes, right? When I submit a proposal, I'm allowed to say, in order to participate in the study, you have to have a cognitive or developmental level of at least 2 years of age. You have to be toilet trained and have no self-injurious behavior. And review committees buy that, and they fund those studies. So the kids may be different too. And so I test my study, and what do I test it against? I test it against treatment as usual. What is treatment as usual, if you ask? I ask too. I don't know. Certainly from what we saw from Allison's study, it's not achieving very positive effects. It's rarely measured in these studies, so we don't know what actually was delivered in the treatment as usual group. But it turns out that my intervention does better than treatment as usual. We don't know if that is the intervention itself or sort of a coaching or interventionist effect. I think some of the people who work on some of these trials, you can put them on a desert island with no manual and kids with autism, and they will figure out exactly what to do. So I'm comparing two very different groups of professionals as well. But it turns out my intervention works. I publish a paper on it. I package it in like very pretty package, and I license it to Western Psychological Services or ProEd, and then it gets sold. And who does it get sold to? Well, it gets sold often to school districts or early intervention systems. And how did they hear about it? Well, they got a flyer or an email, or they went to a one-day training and they thought it was good. And so someone high up in the school district, let's talk about schools for a second, buys it, right? And they say, all right, this is what we're doing this year to the teachers. And so all the teachers, all their professional development that summer is devoted to learning the intervention. And the teachers go, and they go, really? Because we did this other thing last year, and we did this other thing the year before. You know, I'm just going to sit this one out, and I'm going to wait to see what we're doing, if we're still doing this next year. So they are highly varied in their motivation to do this because of the many things we throw at teachers and ask them to do. They also don't receive the same kind of training and supervision that the folks in the university-based trial did. They are in a room very much like this one, and there's someone very much like me up there showing them very pretty videos of the intervention working, and at the end of the videos, they turn to the audience and they say, does anyone have any questions? Nobody has any questions. When do they have questions? They have questions the next day when they're trying to do the intervention. And the question they have is, why is the kid in front of me not doing what the kid in the video did? Right? And so without the additional support that teachers desperately need, that intervention sort of gets shunted to the side. And it also turns out that kindergarten teachers do not get exclusion criteria. It turns out that if you are a kindergarten teacher and you say, I'm sorry, you do not have a developmental age of 2 years, you have self-injurious behaviors, and you're not toilet trained, you may not come into my classroom, that's illegal. And it should be illegal. That's why we passed all those laws protecting the education rights of children with special needs. But it means that the kids on whom these interventions are tested often differ from the kids who we hope will benefit from them in real life. So in some ways, what we do in an efficacy trial is we take out all context, right? We take out anything that could mess with the intervention's effectiveness, right, to test what could possibly happen. Effectiveness is what happens in the real world, what happens when you layer that context on, right? And this became very clear to our group when we did our first randomized trial of a school-based intervention in kindergarten through second grade education classrooms. It was called the STAR program, Strategies for Teaching Based on Autism Research. It's a program that combines discrete trial training, pivotal response training, teaching and functional routines with a curriculum with 169 lesson plans. 68 lesson plans. They got rid of one. And it's very similar to a lot of other comprehensive packages that are available out there. And in our study, we compared it to structured teaching, which is the method of teaching that was developed by Division Teach in North Carolina. And what we found was when we randomized classrooms and teachers to receive training and intensive coaching in either intervention. And what we found was that in both groups, kids improved. So we used the differential ability scale as our measure of outcome, which you could think of as a measure of IQ. And in the STAR group, the average increase over the course of one academic year was 10 points. And in the structured teaching group, the average increase was almost 9 points. Now, both of these are great. 2/3 of a standard deviation on an IQ measure is really impressive effect over one academic year. But we really didn't see any difference between the two groups. But where we did see a difference was when you separate them by how much the teachers did the intervention the way that it was designed. So implementation scientists often refer to that as intervention fidelity, right? How much did you do it the way the manual says you should do it? And when you look in the low fidelity classrooms, so teachers who are not doing the intervention the way it was designed, you don't see any difference between the structured teaching and the STAR groups. In the high fidelity condition, you see a big difference, that among teachers who are doing the intervention the way it was designed, the kids who are in the STAR classrooms got better than the kids who are in the structured teaching classrooms. Makes sense. STAR has a lot more components to it than structured teaching. If you're doing all those components, that's probably better for kids. But the statistic that was really striking to me is the one at the bottom, the average program fidelity. So we measured fidelity on a percentage scale. So 0, you were doing none of it, and 100%, you were doing all of it. We videoed teachers and actually sent them to Aubin Stamer, the videos, not the teachers, here at UC Davis at the Mind Institute, and she coded all of them, not knowing which room the teachers were in, so we could have a really good, unbiased measure of how well the teachers were doing the intervention. And what we found was that on the average fidelity in the STAR condition was 57%. And the average fidelity in the structured teaching condition was 48%, right? So about half of the components in either program is what the teachers were doing. So now, we gave these teachers a lot of training and a lot of resources and a lot of support. And they loved their coaches. I could tell that they loved their coaches because they told us they loved their coaches. But also, so I would just watch at the professional development activities, and the coaches and the teachers would see each other after a long summer, and there would be soft music playing in the background, and they would run towards each other, and they would embrace, and they would show off vacation pictures and new tattoos, and they really had and our coaches were good. Many of our coaches had worked in the public system before, so they knew the environment in which they were working, and then they were all getting intensive doctoral training in evidence-based intervention for kids with autism. These coaches were great, and we were giving the teachers a lot of resources to help them set up their classrooms, and the teachers still weren't doing the programs the way that they were designed. So why? I think there are a lot of reasons to think about why, and I think here's we get to the point where our policies have failed, right? Because our policies are often focused on making those kinds of resources available, not the coaches. We could do a lot more of that, but programs, money, making sure kids are in the right environment, but not on the content of what is delivered. And often the content of what is delivered is not in place because of all the prerequisites that we haven't fixed first. So if I run a school or I run an agency, my highest priority is keeping the doors open and keeping people paid. And my second highest priority is staying compliant with regulations, because that's where most of the policy issues are, and that's what could get me shut down. My third one is retaining the workforce. Turnover in publicly funded agencies is so high, and keeping good people is really hard. in part because we burn them out. Then I need to retain students, or I need to retain consumers or users of my service, and then I start thinking about quality. And maybe while I'm thinking about quality, I start thinking about the use of evidence-based practice. We as researchers, so the policymakers and district leaders or payers, they are focused on staying compliant with regulations. That is the heavy focus of much of our policy. We as researchers are often focused on evidence-based practice. And both groups of people are skipping everything else in the pyramid. That's not consistent with the reality of most of these community organizations, right? So this is another way that I think about it. I love Calvin and Hobbes. Calvin was like my favorite cartoon character. And this is Calvin trudging up a hill, pulling a sled. No one likes to trudge up a hill, pulling a sled. I think of this as frontline workers' lives, right? I think of this as being a teacher in a special education classroom or being a frontline clinician. Your life is hard. You have a lot of stuff that you have to do, that you're responsible for. And we as researchers think we're going to come in and we're going to help you do those things. What we are really doing is we are loading your sled, right? We are giving you these evidence-based practices. We're giving you a thing. Discrete trial training, a new curriculum, pivotal response training, functional routines, extra training. You should want these things so much. But what they do is just make your lives harder, right? Because behavior change is hard, right? We're asking teachers to change their behavior, to do new things, to keep new things in mind, to have new things in their classroom. We've increased their cognitive load in a way that may be very challenging for them. And in doing that, we have failed to address all the challenges that are the things they really want us to take care of, right? Like, we don't pay them very much. I think they'd really like a lot more money, right? We do tons of paperwork. And if we have a new curriculum or new forms we're asking them to fill out, what we've done is just increase the amount of paperwork that they have to complete. They often have resentful staff. We think in our classrooms we have teachers who are often fresh out of a master's program. We have assistants who sometimes have a bachelor's degree who have been in there for 20 years. And so we have really challenging classroom dynamics often, where the teacher is responsible for managing the classroom but has no training in how to manage other adults, right? Just in how to manage other kids. And it creates, we joke that we could give these folks couples counseling, and that would improve outcomes for kids with autism more than any evidence-based practice. In fact, we joke about it so much, we think it might be true, and I think it's a direction we might be heading in, right? You also have irate principals who, especially in more segregated settings where you have a classroom with 8 kids, or where kids are in general ed, but their test scores count towards the school's test score average. Principal doesn't want these kids in their school, and so as a result, the principal often gives the teachers tiny classrooms that they're struggling to manage. So it used to be a broom closet, now it's the autism support classroom. So if we really want to help teachers, before we load their sled, we need to think about policies that address all these boulders that are in their way. And I have another great doctoral student, Hillary Dingfelder, who now Kratz, who wanted to study this in a quantify it. So she went to teachers at the beginning of the year, and she used a standardized measure that's called an implementation climate measure. Right? So this is the idea. We want teachers to do new stuff. How well is the environment set up for them to do that new stuff? And so this measure measures the extent to which teachers feel expected, supported, and rewarded in using particular evidence-based practices. In this case, it was the STAR program, because now the district had decided to roll out the STAR program throughout the district. And she found that the extent to which teachers said that it was expected, supported, and rewarded that they use this intervention was correlated with how much they were doing the intervention in May. So that's great that you can give them a measure in September and it predicts how they're doing in May. That's very unusual. What was more interesting to me was the interaction between climate and fidelity to the program on outcomes. So let's look at the black line. The black line is good organizational climate, right? That means teachers said, yes, it's expected that I do this, I'm supported in doing it, and I feel rewarded for doing it. the more, and on the y-axis is again that DAS measure, right? So higher means kids got better, and the more they did the intervention the way that it was designed, the better the outcomes were for kids. Now let's look at the blue line. The blue line is bad organizational climate. They said, teachers who said, it's not expected that I do this, I'm not supported in doing it, I'm not rewarded for doing it. The more they did the intervention the way it was designed, the worse kids got. So there's a really interesting interaction between the climate of the school and how supported and rewarded teachers feel and the outcomes they get. So let's think about who these teachers are, right, on the blue line. So over here on the right are teachers who said, it's not expected, I'm not supported in using it, I'm not rewarded in using it, but damn it, I'm going to do it anyway, right? Bless their hearts. They were doing as much as they possibly could, but it might not have been the right intervention for that particular setting. So if we look at the other side of the blue line on the left side, those are teachers who said, bad organizational climate, and I'm not doing it. And their outcomes were almost as good as the outcomes for the teachers who had good organizational climate and were doing it with fidelity. So we talk a lot about research to practice. This was a very humbling moment where I started thinking a lot about practice to research. Right? That means there are good things going on in those classrooms. We have a lot to learn from those teachers. And what we should be doing is observing to see what they're doing and how it's interacting with the resources they have available and the support they get that's resulting in such good outcomes. May mean that a one-size-fits-all approach to saying, all right, we are all doing this program is not necessarily the way we want to go. Right? So we started to think about this in a slightly different way, which was to integrate organizational characteristics, organizational theory, and theory of behavior change. Because we started to think that at the heart of what we're asking teachers to do is change their behavior. Right? We know a lot about changing adult behavior. Right? Often when it comes to working with teachers, we throw it out the window. But when we think about things like exercise or diet or drug use or all those kinds of things, we have a very sophisticated theory of behavior change that we've applied in a lot of places. And our thought was, let's see if we can apply this with teachers. So in our model, which borrows heavily from the theory of planned behavior, the idea is that the most proximal determinant of whether somebody does a behavior, like say use a star, is their intentions. When what they say, how motivated they are to do something, how likely it is that they'll do something, and that there are three determinants of intentions. There's attitudes, I think this is a good thing to do or a bad thing to do, a wise thing or a foolish thing. Norms, other people like me do this, or people who are important to me expect me to do it. See those expectations coming in again. And self-efficacy, if I wanted to do this, I could do it. Right? We think skill is also important and may mediate that relationship between self-efficacy and intervention. We see a lot of teachers who think they know how to do this, and maybe the way they think to do it is not exactly the way we think they should do it. But so that's where the skill part comes in. And so how does the organization matter? The organization, which is the thing that's setting the policy and determining practice. Well, in two ways. One is an organization's culture and climate may affect the beliefs that underlie attitudes, norms, and self-efficacy, right? If I work in a place that's very supportive of me and gives me resources to do the things that I need to do, and sends me to trainings and makes me feel good about my job and makes me feel valued, that might increase my intentions by increasing my attitudes, norms, and self-efficacy. On the other hand, if I have an organization that doesn't do those things, I may start to withdraw, I may be less interested in doing anything that sort of puts me out there in a way that makes me feel vulnerable, I may feel less motivation to do a good job, right? And the organization also may affect my ability to act on my intentions. So I may have really high intentions to do something, I want to do it, but I don't have the resources to do it, right? So and I'm going to give some examples where both those things, I think, influence use of very specific intervention pieces that we think should be in every autism support classroom. But first, you have to think about what those pieces are. So what's the behavior of interest? Often when we think about behaviors, we think about comprehensive programs. Like for us, it was do STAR. We want the teachers to use STAR. When we talk to the social psychologists who do this kind of work, and they said, well, what's STAR? And we told them what STAR was, and they laughed at us. They said, that's not a behavior. That's not even a repertoire of behaviors. That's some aspirational goal. What are the specific things you want teachers to do? And I think that this is a thing we often miss when we do program implementation, that we have a huge, complicated program that we want to implement in a community, but that program is composed of a bunch of different parts, and what drives the use of different parts and what resources are needed to do the different parts can really vary greatly. So if we look at these kind of comprehensive programs, on the top left, that STAR, I told you it was pretty, right? It's very pretty. 3 boxes, 3 different colors, lots of folders, right? Or if you think about the Early Start Denver model, or any of these comprehensive models, they are often composed of a lot of different intervention components, right? But we just talk about it as if it's one monolithic thing. So where we focused was on 4 different behaviors after going back and forth with the STAR intervention developers and the social psychologists for many, many months, trying to decide what we would measure and how we would ask about it. We decided there were 4 things that every classroom had to have, right? They had to use positive reinforcement as their primary mode for behavior management. And there's nothing special about these things. I think you would get general consensus from most people about these things. So that could be a token economy. It could be a high praise to behavior correction ratio. So that was the first thing. The second was they had to use visual schedules to help kids organize their day. A third was they had to pull kids for one-to-one intervention every day. We were hoping for pivotal response training. We would settle for discrete trial training, but they had to pull kids. And so this is an excellent example of a teacher with very high intentions and a resource problem that's preventing her from acting on those intentions. She's doing 2-on-1. Why? Because her assistant was out on disability for 9 months and she didn't get a new assistant, right? So she's managing this classroom on her own with no support, and this was the best she could do. And the last thing is you have to collect data, right? And we can talk for lots of reasons about why you have to collect data, to monitor progress, to assist with program planning, to celebrate your successes, to communicate with parents in an effective way, but you have to collect some data. All right, so then we asked teachers about their intentions to use each of these 4 things, sort of as proof of concept. And what's interesting is that 2/3 of teachers say they strongly agree that they will use positive reinforcement with kids in their classroom. I don't know who the other third of those teachers are. I'm a little nervous about that. But it's good that 2/3 say that they will. About half say they're going to use visual schedules, strongly agree that they'll use visual schedules. About 40% say that they will pull kids for one-to-one instruction, and no one likes data collection, right? And think about this monolithic program that we want to implement, STAR. Now, if we told teachers that you have to do STAR, and we are training you in STAR, and STAR is composed of, among many other things, these 4 components. If you were one of the 2/3 of teachers who said, well, I don't want to do data collection, like that's not part of how I teach, you may reject STAR altogether, right? You may not do any of the pieces. But if we break down the pieces, as our coaches have really cleverly figured out, and we scaffold the teacher, remember that behavior change thing? We scaffold the teacher the same way we think about scaffolding kids and help them learn those skills one at a time and implement them, we can eventually get to data collection. But wouldn't it be great if we could get these other 3 pieces in place as well? In fact, we don't even call it STAR anymore. We don't say what we do is STAR. We work with them on evidence-based practices that are going to help them in their classroom. These happen to be the 4 that we focus on the most. So we measured those intentions, and then we did a separate anonymous survey just about visual schedules. And we asked them if they intended to use, I'm sorry, that was anonymous, and now this was confidential. We asked them, so we knew who the teachers were and how they had, whether they had said that they strongly agreed that they were going to use visual schedules. We picked visual schedules because it's the most observable. It's kind of hard to fake when you go, and that we were likely to observe it during any transition in the classroom. So then we paid the teachers a visit a couple of weeks later to see if they were actually using visual schedules. And it turns out, if you were trained in the STAR program, you are almost 7 times more likely to be using visual schedules. That's good. But adjusting for that, taking into account whether you had done that, if you had strongly agreed if you check strongly agree on that statement about whether you were going to use visual schedules, you are more than 5 times more likely to be using visual schedules. Let's put it a different way. Of those teachers who strongly agreed that they were going to be using visual schedules, when we pay them a visit, 96% of them were using it, right? If you didn't strongly agree, only 26% were using any kind of visual schedules. So it suggests that intentions are important, and that if we want to construct policies and an environment in which we increase teachers' use of evidence-based practice, we should be focusing on those intentions and the determinants of those intentions as at least one major contributor to their use of these evidence-based practices. So then we interviewed teachers, and we asked them about why they did or didn't use these different practices. And it turns out that the reasons were very different too. So the teachers who weren't using positive reinforcement was about pedagogy. It was about kids should do what I say because kids should do what I say. And that positive reinforcement or token economies seemed like bribery to them. And that suggests that's one kind of work we have to do with those kinds of teachers. Visual schedules, about resources. Yes, I want to use visual schedules. How do I make a visual schedule? Where are the materials I need to make visual schedules? And so folks started traveling with portable laminator and board maker, and we can make, we'll sit next to you, we'll make your visual schedules, we'll help you figure out whatever materials you have. You just need a whiteboard and we will help you make visual schedules. So that became a resource issue. One-to-one instruction is about staffing. I have 8 kids in my class and you want me to do what with this one kid? And so that became about changing the way we train teachers. That means that in the first part of the year, we're just going to focus on center-based instruction. And by the way, when I say we, I do not mean me. I mean our amazing coaches who are going into the classrooms who are doing this work. And much of this and many of these changes are really driven by their daily experience and the time they spend together brainstorming about how to address some of these challenges. But I'm going to keep using we because it makes me feel good. So for staffing, it became about teaching them center-based instruction for the first semester and putting the one-to-one instruction on hold for a bit, which panics everybody, right? Like, how am I going to make it through the curriculum if all I'm doing is working on classroom management and center-based instruction for the first part of the year? But then you can layer on the one-to-one instruction and you can start really flying if those other 7 kids are engaged, and you're also teaching a tremendous amount of skill that's necessary in an academic environment in that first semester. And then data collection was about attitudes. Every minute I'm collecting data is a minute I'm not teaching my kids, right? Which forces us to go back to the drawing board and say, well, how do we rethink the data collection process so that it's more integrated into the activities the teachers are doing and so that there's less of it? Can we just settle for probe data, right? Can we do very basic kinds of data collection that won't interfere with the teacher's teaching as much? So our strategies to address each of these different components becomes very different. So how does that fit into our model? Well, you could think about 2 sort of different sets of policies and practices that we need to put in place to support teachers. One is for teachers whose intentions are strong, right? So for teachers who say, I really want to do this, I intend to do this, but there's something that's getting in my way for doing it. And there are sort of 3 categories of things we found that could get in their way. The first is they don't have the skill, right? They want to do it, but they really need a lot more support. And that's sort of the easiest thing to help with in some ways, that we could have a coach in there with a willing teacher who's modeling and providing feedback and helping increase the skills. A second is we can remove structural barriers. So structural barriers can be, I don't have an aide, or I don't know what to do with the other 7 kids in my class, or my classroom isn't organized properly. And I think, our coaches could all get second careers as furniture movers, because they spend so much time in the classroom helping teachers reorganize their classrooms in those cramped spaces to make them, to create a one-to-one area with few distractions. And the third are implementation aids. So the teacher saying, I want to do it, but I forget, right? So we need visual schedules for teachers, just like we have visual schedules for kids, right? So that, because that can be a very chaotic environment in that classroom. How do we create an environment that reduces the cognitive load on the teacher? So they just have to look up at the list and know what the next thing is they're going to do. So to work with the coach and develop a schedule. Another possibility is intentions are weak. I don't want to do it because I don't think it's the right thing to do for whatever, or because I don't know how to do it, or because that's not how I perceive the role of someone in my job, right? And so we can focus on attitudes, which are changing the perception of the behavior's utility, right? Working with them to help them understand that this is a good thing to do. I'll tell you, in the first year when we were implementing STAR, our best teacher conversion stories were when a coach would walk into a classroom in the middle of a meltdown. The kids, not the teachers, right? So, and the coach was able to de-escalate the student and get them functioning, and all the teachers like, how did you do that? The coach was like, well, I will tell you how I did that. And that became our entree point. And so if you have those wonderful teachable moments, that's great. If not, a lot of it can be more about training or more helping teachers identify problems that they perceive and showing them how the skill you're helping them develop or the thing you're asking them to implement can address that particular challenge. Make it very relevant to the teacher. The second is to apply normative pressure. And this is not, this has to, remember, there are two kinds of normative pressure. One is descriptive, what do teachers like me do? And the second is injunctive. What do people who are important to me or who are my supervisors expect me to do? We have not had great luck with principals, with those injunctive norms. We have, I think, especially in segregated environments, principals see that as somebody else's problem, right? And those kids are over in that classroom and they're not exactly, and there are notable, wonderful exceptions. But we haven't had much luck trying to get the district to say this is a mandated program, or to get principals to evaluate the teacher in a way that's consistent with the evidence-based practices we're teaching. But you can increase descriptive norms. What do teachers like me do? So one of the things we've noticed about our professional development days is that nobody learns very much, right? I mean, it's great. You can take in a lot of stuff, but then the ability to act on what you've taken in is not as great as it would be if you had a coach in the classroom who's modeling and providing feedback. But what those professional development days can do is create a sense of community. That we could do more sharing and more opportunities for people to learn from each other and create learning communities where it becomes clear that, oh, this is what we as a community of autism support teachers do. Right? And so that's how that community becomes really critical. And Zinnia Piotrowski, who's the director of our coaching program, is actually writing a paper now about the isolation that accompanies many of these positions and what we can do to change that. And I think creating those communities through professional development is one way to do it. And the third thing you can do is increase ease of use. So many of the things we ask people to do are hard to do. We recently completed a study of a computer-assisted intervention for kids with autism. That we did a randomized trial, and the randomized trial showed no effect of the intervention above what teachers were doing in the control group. But teachers loved that intervention. They loved it because it was so easy. They could put kids on the computer. It addressed behavior challenges. Parents and kids seemed to really like it. If a kid was having a tough day, you could, give them some more time on the computer. And it suggests that if we want our evidence-based practices to be implemented and not just work in the lab, we need to think about how to make them a lot easier than they are now. So that's where we've sort of landed in terms of policy. Like, if we want people to use evidence-based practices, that our policies need to land on, and hammer on, what can we do to support people in the classroom or in the community using those evidence-based practices. A handful of years ago, one of my colleagues pulled all of the mostly consent decrees and court orders from major special education lawsuits in the United States to look at what those focused on and the extent to which any of them focused on evidence-based practice, right? So about 15% of them focus on academic outcomes, right, that our kids should be doing better. And encouragingly, more than 40% focused on best practice. But that's not where most of the lawsuits focused. Most of them focus on staffing or reporting. Placement is a big one. And I think what happens is parents bring that class action lawsuit, and then it gets into the hands of the lawyers. And the lawyers are all about regulation, right? They're all about looking at the letter of the law. And many times there are really meaningful violations of that law that have to be addressed, especially around things like school discipline or communication with parents. But often the lawsuit can get away from its original intent, which is to make things better for kids in the classroom, which often means focusing on supporting those teachers and using those evidence-based practices. And I would argue that we need to think about policy options that move away from that regulatory framework and move more to a supportive framework that encourages the practices of interest. And I want to come back to that model, the theory of planned behavior, intentions, norm, self-efficacy, attitudes, norm, self-efficacy, and things that interfere with intentions. And I'm going to end with just talking about listing a handful of policy options where I think we could focus. And then I would love, in our remaining 25 minutes, to hear from you about whether questions you have, but whether you think that any of these might be viable in the work that we all think is so important. So for example, if we wanted to improve teachers' attitudes about the use of these practices, we could link it to position security, right? If we don't often think about performance-based metrics, or when we do, we're thinking about Danielson, which is not appropriate for our kids, or we're thinking about sort of administrative things that our teachers do, rather than thinking about evaluating them based on their use of evidence-based practices. We can also change attitudes by stories. So humans tend not to learn from research. They don't like statistics. They don't randomized trials don't resonate with a lot of people, but stories of success do. And so thinking about within districts whether there are ways to share stories of success among teachers to change people's attitudes about using a particular practice. A second thing is norms, both injunctive and descriptive. So in our district, we have worked very hard with our district with not as much success as we would like to get them to say, this is the mandated program, this is what we were doing. And actually one of our coaches who is in the audience, I'm just going to put you on the spot for just a minute. There's one of the things we ask teachers to do to fill out what we call a student learning profile. And Brianna didn't know we asked them to do it. This was her first year coaching this many teachers. She thought we told them to do it. And so she told them to do it, and they did it. And her rate of success of getting teachers to fill these out was much higher than our other coaches because she said, you have to do this. And that sounds very simple, but we often don't do that. And maybe we want to think about some things where we say, you have to do this. Having clear evaluation standards. Many of our principals have no special education experience. They don't know how to evaluate these teachers. So how do we work with principals to give them clear checklists for evaluating those teachers that are linked to the evidence-based practices we want teachers to do, and consistent messaging? And so if we go back to how these programs are chosen, we often skip from program to program every year, or ask teachers to layer on a lot of different curricular components without prioritizing those components. How do we work with teachers to prioritize them, say, this is the most important thing that you do in this classroom? And then self-efficacy, sort of moving from standard stand and deliver trainings to more competency-based trainings and ongoing coaching and support, rather than expecting teachers to learn everything in a 6-hour PD and then implement it flawlessly in the classroom. So I think those are things we can do to leverage the determinants of intention to increase use of evidence-based practice. There are also things we can do for teachers whose intentions are high but aren't able to act on those intentions the way they or we might like. The first is classroom management. Before we start teaching teachers pivotal response training or discrete trial training or use of a complicated curriculum, we need to help them manage the chaotic environment that are these classrooms. And so focusing early on how to help teachers with that before we teach them other stuff might be a good strategy. Thinking about the realities of staffing in these classrooms, I'm just going to leave it there. But the other thing is, one of the ideas that we've played with but have not used successfully yet, but are intent on exploring, are reminders. So let's think about circle time for a minute, right? So you're doing circle time, and you know that right after circle time, the kids are going to break up into centers, and you're going to start pulling kids for one-to-one instruction. But circle time's going so well, and everybody's really digging the story, and the environment is so calm, and you're kind of loath to leave circle time until a kid melts down. And then you're like, oh yeah, it's time to leave circle time, but it's 5 minutes too late. If you had done it 5 minutes earlier, things would be so much better. So how can we use things like text-based reminders to teachers, or using digital calendars to send them warnings, to push out warnings that say, hey, it's time to transition, remember your transition routine, or having that transition routine come up on their phone automatically, so that we use the digital technology that's already so prevalent in these classrooms to help teachers manage their time, and then on-site problem solving, which again, I think it has a lot to do with the coaches. And the coaches who may ostensibly be there to train in a particular evidence-based practice are probably even more important in their role in helping teachers solve immediate problems. And so making sure that there is time for that in the coaching schedule, and there's opportunities for and resources for teachers to call on. So what should you take away from all this? One is, I think financing policies are really important. I think they're necessary but not sufficient. They're great for increasing access to community-based services, and that's really important, but they don't address quality the way that they're written now. I think the second thing is we need to think very carefully and operationally about what is the thing you want frontline workers to do different now than they're doing, or different in the future than they're doing now, right? And as with us, I listed data collection, visual schedules, one-to-one, positive reinforcement. It took us like 6 months to come up with those things, and going back and forth. They seem so simple now, and they roll off my tongue, and I'm sure they seem obvious to everyone in the room, but it took us really a while to dismantle this more comprehensive program, to think what are the active ingredients and where do we want to focus? And that needs a lot of time. A third thing is, what's motivating to your frontline workers, right? We often think that the motivation should be intrinsic. Right? You went into this work because it's God's work, and if you don't think so, then go do something else. Well, nobody works like that. Well, okay, there's a small fraction of people, I admire them and kind of hate them, right? Who get so much satisfaction, internal satisfaction from what they do. That's wonderful. That's not the reality of most people's day-to-day existence. So how do we think about what is motivating to the people on the front line and incorporate it into the reward system for doing the things that we want them to do? And then create policies that leverage those motivations. And I think, so these 4 things are easy to say. I think they're hard to do, but I'm hoping that that's what the rest of the conversation will be about. Thank you.
You know how when you were talking about psychiatric hospitals and stuff like that, I know Pennsylvania has a school called Vitalistic, and those
has a school called?
They're Vitalistic centers, where they take kids either to Kids Peace or to it's like a school for, I guess, challenging behavior children. Are you familiar?
I'm not.
With that? I was just wondering if that was something that Medicaid mandated too. I used to live in Emmaus in Allentown, and so when my son was diagnosed at Cornell and again in Lehigh Valley, we were summoned to CHOP too, so we were given all this information. So I was just kind of wondering if that was a component that you studied.
So in our data, we wouldn't have included kids who went to approved private schools. If it was a residential school that was paid for through the education system, it wouldn't have been included in those data. Am I answering your question correctly? Okay. Sure.
Good morning. So where do you see, I know there are a lot of parents and parent advocates in here.
Yeah.
So where do you see them providing impact in this decision process?
Oh, thank you for asking that question. So I think there are at least 2 ways that this could happen. One is be an informed consumer, right? I think, ask your doctor about the purple pill, right? We do so much direct-to-consumer marketing now. I think that we ought to be thinking about this for autism intervention as well. And so when you talk with your teachers, when you're thinking about when you're in an IEP meeting, and there are goals for that IEP meeting, it's not enough to have goals, and it's not enough to have outcomes associated with those goals. Although those two things are really important. You want to know, how are you going to address that goal? And when you ask about how they're going to address that goal, the answer you want to hear should be consistent with an evidence-based practice, right? You want them to be able to explain it to you that way, and push the teacher, push the school to identify the practice that they are using to address this particular goal.
Give an example.
All right. So let's say you have a kid who's a runner.
Okay,
Elopement, right? So let's talk about elopement, and you have a kid who keeps leaving from the classroom, and so you could have a goal that you're going to either reduce. Let's say it happens 3 times a day. You want it to happen only 1 time a day or 1 time a week is your goal for the next period. You want to know how they are going to do it. Hopefully, they're going to do.
by data collection, and they're introducing 8% of the time. Go ahead.
You come on up. Give her a mic. So, but you want to know what that. So you probably want you want to understand the function of the elopement behavior, right? And so you want to know how they're going to identify the function of that elopement behavior. And so let's say it's because the kid is bored, right? So how are you going to engage that child? How are you going to increase rewards for the kid not eloping or participating in other classroom activities? And you want that very, very clearly spelled out. Does that make sense?
No, because I want to know, you said, how are they going to do it? How are they going to stop the movement? So how are we going to do the supports that you said?
Oh, so how do we go from there to this?
Yeah.
Well, so that is,
We want to support the teacher, right?
absolutely we want to support the teacher.
So that's
So
what I'm saying. So how are we going to help that teacher?
good, so let's go to the next step. So hopefully in your IEP meeting, it's not just you and the teacher.
Okay, it's the school administrator that can speak to the supports.
Right, so one of the things you want to know about from the teachers, do you know how to do that? Is that something with which you've had experience?
Yeah, because I have a kid.
No, sorry. I'm saying that's the question you're going to ask the teacher. Do you have experience doing this?
Yeah,
You know-
I've done this for the last 15 years, he's going to say.
All right, so one of the things I'm hearing in your tone is the potential for an antagonistic relationship with the. Okay, good. I'm glad to hear it. So you can ask them about the last time they did it and what they did and how that went. You could ask the teacher if she feels like she has all the supports in place that she needs in order to implement that particular piece of the intervention.
I've had 10 kids like that.
Well, so if she doesn't want to get specific, this is always a dance, right? About how you're going to try and create a positive environment for your child in the school without being that parent, right? Without being the one who's.
It's not about being that parent. It's about the IEP goals are written they're not.
Can you come
written-
to the mic so that other people can hear you as well?
It's just the truth is that the IEP goals are not written that way. They're truly not. They're written based on goals are written based on assessment. So the assessment says the function of the elopement behavior is because the child is bored. So we're going to teach these skills to make the child less bored, right? So there are goals based on that. But you're saying we need to support this teacher, right? And we want to give the teacher the resources, okay? Because we want them to be more successful, because this is what this is about. This
Right.
whole lecture is about. It's not really about, it's about the kid, but really it's about making the teacher more motivated and
Absolutely.
giving them the resources. So it's kind of like, it's all about in the IEP, whatever the goals are, to make that teacher supported.
So if the teacher says that she's been doing this for 15 years
Yeah.
and she knows how to do it well, then you're in great shape.
Exactly, but like if it's a goal and the teacher has, 8 students and just it's her and one other aide. So how can I make that teacher more supported? Do I, for example, how can I get her another aide?
Well, that's something you may not be able to do. But I think what you can do is be an informed consumer.
Okay.
What you can do is ask that the supports are in place. And it's an opportunity, if the teacher says, yes, I know how to handle this, and like she may not need another aide. I am not a huge fan of stuffing more adults in these classrooms, right? But she may feel like she has the resources in place.
And
you'll
you can't
know.
lock the door. Like, is somebody going to be able to like be seated next to the door?
If that, so one question is that necessary, right? So these are all great questions to ask, and then I think the next question is, are the resources if we are agreed about what the plan is, are there resources in place to really carry out that plan? So it's not enough for her to say, yeah, I've been doing this for 15 years, right? You really need her to articulate what the specifics of the plan are, and then that's an opportunity for you to ask, well, are the resources in place for that plan to be carried out?
Okay.
Right.
One just question. Have you ever seen when you come across like the resources, an impediment to getting the resources, like issues, you said the principals were not very helpful. Has an issue been like unions or things like that?
In this particular case, I don't know that we've had union issues per se, although other people may have. I think the bigger challenge is often teachers or schools or folks saying, we don't do that, right? And then you have a whole set of other challenges that you need to take on. Here, we're going in with the assumption of goodwill, right? We're going with the assumption that everybody wants to do the right thing. They may not know what the right thing is, and they may not know what resources are in place to do that. I want to give other people a chance to comment.
So I did have a question, but I wanted to answer this mom.
Yeah.
So I'm an ed specialist, inclusion teacher, 12 years, and just now leaving the classroom because of the policy not touching the practice. So I'm moving into more advocacy role. But I wanted to tell all parents that your school district belongs to a SELPA, and every SELPA is mandated to have a community advisory committee that is staffed by parents, teachers, and administrators. So the other thing I would say in defense of teachers and gen ed teachers and ed specialists, you said expected, supported, and rewarded. It is certainly expected. It is not supported. And it's so easy to reward something that's poor practice because it feels good and it makes the administrator feel like they're cracking that whip and pleasing that parent. But when you are, we're talking about superintendents, I think you said, are buying, taking the research and saying, okay, this is what we're going to do, and we just need to get those darn teachers to just start doing this and that and the other thing. But what's happening is that kind of mindset, and I should tell you, I'm on the MTSS Bright Spots work group for CDE, and this is the issue that we keep. I'm the only teacher on that work group, and that is deeply problematic. But what happens in that mindset is that the vision becomes a poster on the wall, and the mission becomes cowboys in the field. And you've got, these really highly motivated teachers who spend every day looking into your kids' eyes and wiping their nose and tying their shoes, and they become our children. And we want to do what's best by them, but we are the people in the system with the least amount of agency to make programmatic changes. Your system wants to work in silos. Your teachers want to team. And so when this policy is coming down and it's going to LEAs, it would be a love letter to teachers if we could stress the importance of, it's not just giving the teacher strategies. You need to talk to those superintendents and those decision makers at the LEA level and tell them, you need to restructure your professional development time. You need to restructure your weekly staff development time so that teachers can work together. Weekly staff meetings are just an homage to the superintendent, and principals are just there to make sure that you give him or her data that pleases him, but it's not student-centered. And this is the work we're trying to do at CDE, and it would just be really helpful if we could just connect that policy idea. That those planks are missing. I really appreciated that cartoon. So I'm taking that back to the work group because we need to stop focusing on what the teacher is or isn't doing. And we do need to support the teacher, but we do that by talking to the decision makers and making sure they understand that, an IEP is a multidisciplinary assessment, and that's a beautiful thing, and that could be a benefit to every student on that school site if we train the ed specialist and the speech therapist and the school psychologist and the nurse and the gen ed teacher to move from multidisciplinary to transdisciplinary, because that is the most pragmatic use of resources, and it fits the MTSS model.
She's been waiting. I had a more practical answer for the parent. I'm a parent too, 5-year-old, and I've had 3 IEPs, 2 of which went nowhere. Great teacher. But the third one, he actually exceeded everything. And the one thing that the teacher did, little trick, was she laminated like a little cheat sheet of the IEP and put it on a big ring of each child in the classroom and carried it around and just reflected on it. And my question in the IEP was, okay, I've had 2 IEPs, they've gone nowhere. How are we going to get this IEP to get some lift? And she showed me that, and by the end of the year, this year, exceeded everything on that IEP, and it was a lofty IEP. So I just thought that was a great, it was the visual for her that reminded her, and I also thought, oh my gosh, wouldn't this be great for every teacher and to meet each child in the classroom where they're at, like in an inclusion setting.
So I love that, and so even teachers with the best of intentions, you have all these kids, how are you supposed to remember? And so the idea that you would carry around a checklist with you is a wonderful strategy.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.